Welcome, everybody. Today, we're going to talk about distress tolerance skills with an expert we have here. It's Dr. Sabrina Darrow. But before we jump into that, I'm going to pass it to Dr. Lindsay Brewitt for a mindfulness activity. Lindsay.
Dr. Holloway. Nice to see everyone. Thanks so much for being here today. Happy Thursday. So for our mindfulness, as usual, you're welcome to turn off your camera or leave it on, whatever you prefer. So wherever you are, I invite you to get comfortable where you're seated or standing, as the case may be. Take a breath and settle in. Mindfulness is always an invitation, so you don't have to participate, but you are welcome to. We're going to be doing a visual mindfulness practice today. So I'd like you to take a look around the space that you're in. And just using your eyes to explore the space that you're in. Your mind will wander because you're human. You can do your best to bring it back to focusing on what you're seeing with your eyes. You can notice things close to you or far away. You might tune into colors, textures, bringing your attention back to what you see if it's wandered. And when you're ready, you can bring your attention back to our echo. Folks who are able, we love to see faces. It helps us get to know each other and feel a sense of community. So if you can turn on your cameras, we appreciate it. And we understand that not everybody can. I'll turn it back over to Dr. Holloway.
Thank you, Dr. Brewitt. I'm just going to make one note. I see that there's an autopilot. We're probably going to kick the autopilot out only because this is already recorded, so you can come back and check this. And at some point, we're going to talk about specific case examples, so don't want to have that recorded. So just to let you know. So it's my pleasure to introduce our speaker for today, our esteemed colleague, Dr. Sabrina Darrow, who is the program director and clinic director of the CBT Wavefront program at UCSF. Dr. Darrow is an associate clinical professor and licensed psychologist in the Department of Psychiatry and Behavioral Sciences. Was trained at the University of Nevada, Reno, the Southern Arizona Veterans Healthcare System, and the T32 Advanced Postdoctoral Training Program at UCSF. Dr. Darrow has expertise in dialectical behavior therapy and cognitive behavior therapy, implementation of innovative clinical services, and building collaborations with community-based organizations. Dr. Darrow, it's a pleasure to have you here. I will pass it over to you to talk about distress tolerance.
Thank you so much. Wow, I even got esteemed in that intro. Might be the first. Nice to be here with all of you. Let me just pull up my slides. Hard to do two things at once. Here we go. All right. So yeah, I'm here to talk to you guys about, what kind of skills do we talk to teens and families about using for like the heat of the moment? So a lot of my work is around teen self-injury and suicide. And I'm going to start off by talking a little bit about that and kind of when I use these skills, and then get to some skills by the end. So before we dive in, here are the disclosures that we have. And I'll just breeze through those because I wasn't instructed to do anything else. So learning objectives for today. So identify elements of evidence-based interventions for self-harm. So there's some things that I just can't help talk about when I'm talking about when we're using distress tolerance skills. Then eventually kind of talk to you about how I talk to youth and families about crisis of behavior, so about self-harm and suicide, and then also teach you two specific skills that I teach to youth and families to use in crisis moments. So one of the things, I work with teens, I work with families, and doing dialectical behavior therapy. I do provider trainings, and I do parent workshops. And whenever I'm talking about self-harm, suicide, distress tolerance behaviors, the way I teach about it is the same way that I teach and interact with youth and families about it. So even just there, how I'm going to be talking to you about all of these things, this is exactly how I would do it with the families and youth themselves. So first I want to start off and give us some definitions just so we're all on the same page. So suicidal behaviors, we often we break these down into different categories. So thoughts, also known as ideation. This is thinking about or considering suicide. So we could also usually break it down for risk purposes to understand if it's active, where people are actually have plans and thinking about how they might go about hurting themselves, or passive thoughts. I think this is one that, like when you're doing a risk assessment and somebody is talking about having a low mood and they say comments like, well, I just don't want to be here anymore. Those kinds of comments, those thoughts might indicate suicide ideation. So worth following up on to understand whether or not that might be a more passive type of thought about suicide. And then, of course, there's actions or attempts. So this is any non-fatal, self-directed, potentially injurious behavior with the intent to die. And so one of the things I like to talk about when we're assessing risk, especially with youth, luckily, there are people that make attempts that don't work. And sometimes youth even pick ways of hurting themselves that are not likely to work. And those we would still label intent or label as an attempt if there was intent to die. So just I'll tell you a little bit more about why I pay attention to all of those things in a second. And so then distinguishing suicidal behaviors from non-suicidal self-injury. So this is intentional destruction of one's own body tissues without suicidal intent for purposes that are not socially sanctioned. So, ear piercing, socially sanctioned, hurting body tissues. Although some individuals do pierce themselves for a more self-injurious purpose versus just like having decoration on their body. So sometimes there are tricky situations. So often when I talk about, probably for the rest of my 15 minutes, I'll just talk about self-harm generally. Sometimes it's really important to make a distinction between these two or these different categories of behaviors. And sometimes it's really hard, especially if you don't have a lot of time to do an assessment. So common myths about suicide and self-injury. So I'd like to bring these into my presentations because I hear these from youth and family, and I hear them from providers as well. And so these are some, if you have questions, you're like, why is this a myth? Maybe I'll talk about a little bit of them. I probably won't get to all of them. But if there are questions about why these are myths at the end, happy to address that if I haven't. So the first one, asking directly about suicide will make someone suicidal. So there's actually lots of data that says this is not true. There are some caveats. If somebody isn't thinking about it in the moment and you bring it up, like, well, yes, then like we all are having thoughts about suicide because I'm saying the word suicide right now. It doesn't mean that you're actually increasing the likelihood that they're going to go act on those thoughts by asking them, right? So you're not increasing risk by asking directly about it. And in fact, as I'm being very direct about these behaviors, this is what we want people to do when you're doing an assessment, when you're worried that somebody might be injuring themselves or at risk of self-harm. If someone says they're thinking about suicide, they have to be hospitalized. I'm hoping I give you a tidbit about that when we talk about like what are the evidence-based interventions to decrease risk. Hospitalization isn't one of them. Hospitalization is a tool to keep people safe in the moment, but it does not actually decrease their risk in the long run. And in fact, when somebody gets out of the hospital, that's actually a higher risk time for many people. So then kind of a lot of myths about like how serious self-harm has to be, or how serious is it, that lots of people are doing it, that it's just a phase that we may not have to pay that much attention to it. So I'm going to skip to my next slide and tell you a little bit about why I don't think that's true, and the data doesn't say that that's true. So we know suicide is the second leading cause of death for teens and young adults. So it's a really serious problem, and not everybody is engaging in it, right? So 20% of youth think about suicide, 20% of youth engage in non-suicidal self-injury right? So that's a lot of kids doing this that we really don't want them to do, and it's not everybody. And then the other thing that we know is that we really have a lot of limits in our ability to predict who is going to be at risk for dying by suicide. And the things that we know that are the best predictors are, having engaged in these types of behaviors before. So non-suicidal self-injury puts a teen up to like 9 times higher risk than a teen who has not engaged in self-injury. And that's not really looking at, that non-suicidal self-injury that required medical attention or not, right? It's just anyone who engages in that behavior is at higher risk for suicide. Thinking about suicide and past attempts, those are our strongest predictors. So that's why I pay a lot of attention to these. All right. Elements of evidence-based interventions. So this also, this top one really gets at the, one big takeaway that I would want everybody to get from this is that it's important in any interaction with somebody when they are if they have a history of self-harm to maintain that this is not an effective behavior, right? So we do, we talk with families and talk with providers about like, how can you express understanding and validate teens' emotions, understanding their emotions and why they might do this, and still maintain that this is not an effective solution to, it is not an effective behavior. So that is a key piece of any evidence-based intervention for self-harm. Decreasing self-harm has to be a priority. So that, these elements are pulled from the interventions that we have that are effective at decreasing self-harm in the long run are outpatient interventions. So each time when we meet with somebody, we're prioritizing decreasing that self-harming behavior. It's something that we address each time. We do safety planning that includes parents and caregivers. Crisis survival skills, that's what we're going to talk about today. And then this, while it's the same size as all of these other circles, is where the bulk of the work is, the actually teaching kiddos behavior change skills to address the underlying emotional challenges that are putting them at risk for self-harm. So all 5 of these need to be present for somebody to for an intervention to be effective at decreasing these behaviors. So a tiny bit more about how to talk about crisis behaviors, right? Self-harming behaviors. So be direct, just like I am right now. In any assessment where we want to ask directly, and we want to maintain that self-harm is not effective. You all work with teens, so you know that they don't always love the things that you ask them or tell them to do. And so if you get pushback, we want to still assert that you're asking about these behaviors to help, right? If you're working on a safety plan with them, you're doing it as a way of helping, even if they don't see it that way. And but you won't argue the point, right? Just assert it and still do it. And then really trying to to look for ways to validate their emotions, to acknowledge, the struggles they're having, to acknowledge their perspective on things. So even their frustration with you persisting and asking about something that they may not want to talk about. I know some of the previous presentations have really talked to you about behavioral approach and breaking things down into the antecedents, things that prompt behaviors, the things that we want to change, and the consequences. So that's so this slide is kind of using that same framework and talking about the things that we do when we're really trying to address safety. So things about antecedents, this is why we talk a lot about means reduction being the most important part of a safety plan. So decreasing access to lethal means or means that one uses to self-harm is a way to decrease self-harming behaviors because the thing's not available. Or reminders of skillful behaviors, things that they can do in those situations where they're distressed to do that would be more effective. The behaviors, so that's what I'm going to spend more time talking about, right? What do we want people to do in those moments when they would be thinking about and having urges to self-harm? We want them to do distress tolerance skills or crisis survival skills. And this if they do a skill, it gives us something else that we can reinforce. And so this is probably just going to skip over it, but more work has to be done looking at how to decrease reinforcement for ineffective behaviors and increase reinforcement for safety promoting behaviors. All right, so a little bit more like how do we think about self-harm and then when we would want to be using distress tolerance skills. So we all experience emotions differently. So time here is on the bottom, intensity of an emotional experience on the side. So sometimes we have emotions that are kind of low level but hang around for a while. Sometimes we have emotions that come on all of a sudden and they're really intense, but then they go away. This is like my Italian family, which is like everything's fine, and then they're like super pissed, and then the next moment they're making you pasta. And then some people experience emotions that are really intense and they hang around for a long while. And we find that this is kind of when self-harm often occurs, when individuals are experiencing intense emotions and they're hanging around. They're not going away. And it's often something that's done impulsively, right, in the heat of the moment. And so this is the time that we want people to be using crisis survival skills. And so the first step of kind of talking about using these kinds of skills is to know, like, what are those moments looking like? Is it when somebody's feeling super hopeless and depressed and they're stuck in bed? Is that the crisis moment, right? Or is it like when you're just like feeling really ashamed about how things were going with friends and also that your parents are getting mad at you and you don't have the privileges you want, and right? So what is that kind of like boiling point where emotions just kind of take over? You're acting on emotions. In DBT language, we call it emotion mind, right? Emotions are driving the ship. You're not thinking straight. What does that look like? So that's the first step up to using these skills, is to figure out, like, when are those moments happening? And then the core, what we're really trying to get people to do in those moments is actually to distract away from the crisis and the urges and thoughts that are going along with them. So it's not a time that we want them to try to do some like problem solving and figure out, like, well, how could you have better friendships, or how could you feel less depressed? It's really just a time to distract away. Oops, this animation didn't work out. So when do we want people to be using them? Well, we don't want to wait to the top of the curve, right? Because that's when your emotions are taken over and you're just doing some action. But we want you to be able to like be mindful, notice things are heating up, and that's when you're using those distress tolerance or crisis survival skills. And a thing I say when I'm teaching these, and a helpful reminder if people are like, well, distracting away from your problems aren't going to help. It's right. It's true. This is not the bulk of, this is not all that we need to do to address emotions and to cope effectively with emotions. And it's super helpful to avoid acting on crisis urges and making things worse. So the first skill that we talk about, and I'll spare your ears in case you have headphones in, but when I teach this in my group, I just yell, stop, right? Like, that's what we need you to do, is to notice, like, oh, shit, I'm getting into one of those crisis moments. Things are heating up and I just need to literally freeze. So the acronyms are heavy in DBT language. So what does it mean? What does it mean when we stop? Like, literally just freeze. Stop, like, take a step back, what's going on? Okay, I'm, had a hard day and mom's, not doing the things I wanted to do. Now I'm having these urges, and proceed mindfully, right? So the mindfulness exercise like we did today, we do a lot of that in DBT, not with the goal of making people Buddhist, but with the goal of how do they start noticing their experience so you can be more aware of when things are heating up, when you're getting into those crisis moments, when you might have those urges, and when skills might be important. So this is essential, right? To be able to recognize those moments in any way. So it's like, there's not a lot to say about this, right? It's really hard to do. And it's like this essential first step. All right. And so then here's another skill, and I'm going to put this in the chat really quick. If you want to save this link for later, and I'm sure it will be in the resources that you get, but this is a video of my colleague walking through this skill and teaching it. So a good reference and a good resource. So accepts is this acronym that we use for all these different ways that you can distract away from the emotional experience that's leading to crisis urges. So A is for activities. So this is where, if you know this kiddo, or, parents are there and they're like, oh yeah, they're super into watching cat videos on YouTube. Awesome. Whatever activity is going to suck you in and grab your attention, this is what you want to then use in a time of crisis as a skill, right? So distress tolerance skills are not like, we all use them. What makes it a skill is you're using it at a particular time when you really need it to avoid acting on those urges. So this could be, reading a book, it could be watching videos, it could be playing a game by yourself, with somebody. Participating in school could be a distress tolerance skill if it was effective at sucking your brain away from the things that are causing you distress. Contributing. So this, sometimes there are ways that we can contribute just like in our environment, like helping out your younger brother do their homework. You're pissed at mom, so don't go help her, but like go help your younger brother or somebody else that's around do something. And focusing on somebody else can be a way to focus away from the distress that we're in. Comparisons is one I always, bring up with caution. And really the idea here is to just like have a lot of different options that people could use. You don't have to use all of them. You just have to find one that's actually going to work for you to distress away from those crisis moments. So comparisons might be, sometimes people find ways to compare how they are feeling to like the suffering that other people are going through in the world, and that can make their distress lessen. Or just be a helpful distraction. Comparing yourself to like a time when you experienced the same thing but didn't cope as well also can be a helpful distress tolerance skill. And it's like one to use with caution, because sometimes comparisons are the things that make us feel worse. So don't do it then. Emotions. So often creating a different emotional experience is a great way to distract. If you're feeling really sad, this might not be, trying to create happiness. That might be too much of a stretch to do like the opposite emotion, but doing something that's a sidestep, like watching a scary movie, right? I mean, I never watch scary movies. I hate them because I get so sucked into them, but it would really be a good distress tolerance skill for me if I was really stuck feeling sad. So pushing away is exactly what it says. In whatever way you can, take a little vacation. Thoughts. This is, replacing, if you're experiencing an emotion where you're having lots of racing thoughts, focusing on other thoughts, playing Sudoku, doing a word search, trying to translate lyrics to your favorite song into a different language. Something that's going to just really make you think different thoughts. So you will also notice if your mind drifts away back to the thing that you were, worried about, the crisis, then you come back to it. And then sensations, creating strong sensations, biting into a lemon, holding ice, and taking a cold shower, anything that's a strong sensation that will pull you out of that emotional experience. What's nice about having, all of these options, just because, well, you have lots of options and not everything works for everybody, but also you can match some of them to the types of emotional experiences that people are having. So for somebody that's experiencing anxiety, thoughts can often be really helpful if the way they experience anxiety is a lot of worry thoughts. I probably wouldn't pick something that's like an internal focus for somebody that's experiencing anxiety. Often we want to pull their attention outside of themselves, because that's really to help, because emotions are full body experiences. So not only is it affecting our thoughts, but it's affecting our internal experience. And if we are really focused on how that internal experience is affected, then that just is going to increase the emotional intensity. I have one more bonus skill, but I don't think I have the time for it.
If you could do it in 2 minutes, we could do it.
All right. The bonus skill is TIP. So another acronym. So the idea behind this skill is to tip your body chemistry. So for exactly the reasons I was just saying, emotions are full body experiences. And so we know that many emotions are activating experience in the way that they are activating our sympathetic nervous system. So all of these are ways that you can tip your body chemistry and activate your parasympathetic nervous system. And here's a YouTube video with my colleague walking through that one. The one I'll say, if you've never tried this, you should do it. Do an ice dive. Get a bowl of water, put some ice in it, and stick your face in it for as long as you can. Don't do it if you have any heart problems. We're not going to recommend this for kiddos, especially that have eating disorders. So anything that impacts your heart, because it actually kicks in this diver's reflex. It's quite intense. It intensely tips your body chemistry. Check it out, try it. Intense exercise. This is where you're trying to match your physical energy to your emotional energy. And then when you stop, they both come down together, right? So do as many burpees as you can, not because they're fun, because I don't think they are, but because it's effective to pull your mind away from your emotional experience. And then you stop and it can help everything calm down.
Amazing. Thank you so much, Sabrina. We have a couple minutes before we need to transition into our case-based learning. So does anyone have maybe one question for Sabrina? And/or I'd also invite folks to put in the chat if they have found any distress tolerance skills that they really like using, that their patients like using. We can take a few moments to kind of share together before we go into the case. And yes, thank you. If everyone who's able can turn their cameras on, that would be awesome. Counting colors is a hit. I agree. I love the counting colors.
One of my favorite newer ways to teach pace breathing is starfish breathing. If you guys have heard of this, so breathe up when you go up the finger, down when you go down the finger, up, breathe in, breathe out. So you're tracing a starfish, you got sensations, you got deep breathing, and it's a starfish, which is fun.
Awesome.
I love that.
I can share. I have a 3-year-old daughter, and Sesame Street and Daniel Tiger have really good deep breathing videos and songs, and they're all publicly available. So if folks are working with younger folks, those can be fun ones to look at. Also, it can work with the contributes. Like I love Sabrina's idea about, do they have a younger sibling that they could teach Sesame Street deep breathing to? Then they're contributing, but they're also doing it themselves.